Good morning, good afternoon, good evening, and welcome to the second Lunch and Learn workshop, Identifying Key Considerations for Program Implementation, presented by the International Hospital Federation in collaboration with Charité Berlin, Mayo Clinic, and Teladoc Health. Before we officially start this workshop, we would just like to remind everyone with a few housekeeping reminders. First, attendees will be on mute through the whole session. For the Q&A part of this session, we would like everyone to send in their questions via the Q&A function at any point of the session. The link to the session recording will be shared in a few days' time, and the link to download this session's worksheet is provided in the chat box. And lastly, to all our attendees, please keep your camera off throughout the session. And now, to officially start this workshop, I would like to call on Ed Percy, Vice President of Teladoc Health. Ed?
Thank you, Karen, and thank you for your help with the session. Depending on where you are in the IHF universe, good morning, good afternoon, good evening, but hopefully not good night. Myself, our esteemed panelists, and the IHF are grateful for your participation today. This particular session is the second in a series of 3 Lunch and Learns, where my friends from Charité and the Mayo Clinic will share with you their best practice approach to delivering a sustainable virtual care program. And joining me this week, and I'll introduce them more fully through the session, are Dr. Jennifer Fang and Ms. Beth Kriofsky from the Mayo Clinic in Rochester, Minnesota, and Dr. Björn Weiss from Charité in Berlin. The previous Lunch and Learn was focused on helping you understand how to match the need of the patient to the telehealth program. And our panel shared some great insights that you can find in the recording, which is available to IHF members. Today's session provides another opportunity to learn from the panel's extensive experiences in telehealth. This time focused on the opportunities that can be presented by a telehealth program and the challenges that can be encountered by such an initiative. I'm certain you will find value in the deep experiences in transforming healthcare that will be shared with you today by our panel. And it's my absolute pleasure to introduce you to my friend, Dr. Jennifer Fang of the Mayo Clinic. Dr. Fang is an assistant professor of pediatrics and serves as the medical director of Mayo Clinic's teleneonatology program, working closely with Ms. Kriofsky. Dr. Fang has published extensively on teleneonatology and is frequently invited to share her expertise nationally and internationally. And aside from Dr. Weiss and Ms. Kriofsky, there's no one better to learn about operationalizing a telemedicine program. Dr. Fang, please, over to you.
Great. Thank you, Ed, for such a nice introduction. We'll first start with an overview of our program here at Mayo Clinic, and then Dr. Weiss will go through the Charité program. And then to kind of set things up for our session today, we do want to recap the highlights from session 1, where we talked about matching the telehealth program to patient need. And then our discussion today will first lead off with identifying your stakeholders that will really be crucial to program success, and identify strategies where you can achieve buy-in from those stakeholders. And then we'll move on to understanding really the issues that are fundamental to both workflow design as well as program implementation, because that will be really quite key to having high utilization of your acute care telemedicine program. So just starting with an overview of our program here at Mayo Clinic. As Ed said, I serve as medical director for our teleneonatology program. So what is teleneonatology? So here at Mayo, we've established a telemedicine network that allows our specialists in neonatal critical care to be at the bedside of neonates in smaller community hospitals or rural hospitals when they require advanced resuscitation or critical care. We're commonly supporting pediatricians, family physicians, and then advanced practice nurses or physician assistants. So our program was established back in 2013, and actually as of now, we've performed over 800 consults since program inception. We serve 19 hospitals in a 2-state region. And because of the nature of our program being, acute care and resuscitation, it is staffed and available 24/7. And it's our now 10 board certified neonatologists that provide our consultations. And really the overarching goal of our program is to make sure we're able to provide our newborns with the right care where they're at when they need it. So
my friend is going to share his experience in the domain of adult critical care. Dr. Björn Weiss is a consultant in critical care medicine at Charité of Berlin, Europe's top academic hospital, from where he currently coordinates the tele-ICU program at Charité with more than 40 remote sites around Germany and in worldwide locations from Uzbekistan to South Africa. Dr. Weiss has published extensively on critical care medicine and is a frequent presenter at international conferences. Dr. Weiss, over to you.
Thank you very much for this kind introduction, Ed, and good morning, good afternoon, and good evening to all participants. So we have one of Germany's largest telemedicine critical care networks. It has been established in 2018, and it's actually a network that connects intensive care units in the metropolitan area of Berlin and Brandenburg in Germany. We have since then performed over 15,000 consultants, and we work in a network of 28 sites in 2-state regions in Germany. Our main aim is to improve the quality of care in the region, and we use a continuous staffing model with 24/7, 365 days per year. We work in a round and response model, meaning we have fixed times for rounds where we actually see patients in different hospitals, and we also have the opportunity to respond to urgent calls. There are 9 board certified intensivists working in an interdisciplinary and multi-professional model. So we really try to enhance recovery after intensive care, and we do that beyond COVID. Thank you very much.
Many thanks, Björn, for that overview of the landmark program with Charité. And I'd like to invite Jennifer or Beth to provide any additional commentary before we move on to the next part of the program.
I don't have a lot to add here, except to say hopefully that by providing all of you with some background on the type of care we're providing via telemedicine, it gives you some ideas and inspiration as you're building or planning to build your programs within your organization. And just looking at people's comments in the chat, it's just so wonderful to have such an international representation here at our Lunch and Learn webinar. So excited to keep moving forward with content.
All right, thanks, Jen. And it's always great to see the international interest in virtual care. So having done a short overview of the 2 programs from Mayo and Charité, we're just going to spend a minute or so recapping on highlights of session number 1, which was all about matching the telehealth program to the patient need. So this is a fundamental step to ensure the successful outcomes of any implementation of a virtual care or telehealth initiative. Specifically, clearly identifying the measurable outcomes of the project, those outcomes that will be improved by your telehealth intervention program. This is effectively the definition of value within the program. Developing a specific use case as an example of how to communicate that value of the program, especially reflecting on what patient need or quality gap is going to be addressed by this new service. Clearly defining the patient population to be addressed by the program. For Mayo, it's neonates who require specialist attention. And for Charité, it's managing challenging critical care settings in an adult critical care environment. And then finally, Well, the final key takeaway from session 1 was the need to evaluate whether telehealth would be an effective solution using perspectives from both the originating or the hub site and the distant sites, as we use the term spoke sites, so in a hub and spoke model. How do we evaluate whether this has been a successful program? And the links that are at the bottom of this slide will take you to a summary of the session and the full recording of the session. So now we begin to look at how to identify the stakeholders who are important for program success and learn how to gain their buy-in. And to begin with, I'm going to invite Dr. Fang from the Mayo Clinic to walk us through their approach to identifying those key stakeholders.
Perfect. Thanks so much, Ed. So I think we wanted to lead off with this for this session focused on program design and implementation, because identifying and engaging your key stakeholders is, again, very fundamental to programmatic success. As you can see, in our first statement, pretty strongly worded, is that your successful implementation and utilization is dependent on stakeholder engagement. You need to identify who needs to be aware of your program, endorse your program, and then really buy in. And then think about the strategies you'll be using with those stakeholders to successfully implement your program. So if we first think about identifying stakeholders, you're going to notice that this is going to happen really across different levels and different areas. So for example, there are likely stakeholders within your hospital's organization administrative team that will need to be aware that you want to build, design, and implement the program, and will likely need to offer some sort of endorsement, because with endorsement typically follows the resources that you'll need for the program. So whether that's additional personnel or whether that's telemedicine technologies or other support staff to get the program in place. So thinking about who are your administrative partners that you need to be working with. And again, the work that we talked about in the first session is really going to pay off here, because you've done all of the work in identifying the value your program is going to bring, and you can communicate it to these stakeholders relevant to their role to achieve that buy-in. So thinking administratively, who you need to engage with. Also, likely there are going to be leaders within your department or within your division that you need to sit down with, let them know your plans, communicate why this program is needed for your patients, for your families, for your staff, and have their buy-in as well. And then I think perhaps most importantly is recognizing who are the people that will be engaging or activating your program, because you want to pull them in early and have them involved in program design as well as program implementation. So to give you an example for us for teleneonatology, in addition to making sure we had administrative support, that our department and division chairs were approved of the program, I needed to speak with my colleagues, my fellow neonatologists, to say, here's what we're thinking of doing. Here is why we want to do it, to help support our colleagues in community hospitals, to elevate the care we provide to these neonates when they're born in rural hospitals but need advanced care. And I needed to really gauge whether or not this was of interest to them and bring them into the program early on. Similarly, when we think about that originating site and the rural or community hospitals, again, extremely important to actually get out to those hospitals, understand their practice, what the gaps are that they're experiencing, and then really almost pitching the program to them to say, hey, based on what I'm hearing from you about, the kind of stress or anxiety your team experiences when you have a very preterm baby born in your community hospital and the challenges you face, we're thinking of implementing a telemedicine program so that you can bring a device to the bedside. Our neonatologist can actually be present with you and see the infant and work with you and provide step-by-step guidance to you during these really complex resuscitations. What do you think? And really, again, bringing them into the project early. And it's very helpful, we have found, to find oftentimes both a physician and a nurse champion that you can basically work with throughout the project. So again, this idea of identifying stakeholders, getting their awareness, endorsement, and buy-in, making sure you're communicating the value that you beautifully laid out based on the work, that was done in our last session, and involving site personnel. Fundamental, again, to all of this are going to be the relationships you either have in place or that you build between, let's say, you as the distant consulting site with the originating site. We have found that there really needs to be a high level of trust that, let's say, Mayo Clinic was coming in with very good intentions that were based on partnership and collaboration and offering additional and really more effective support to staff. It was not about us coming in to critique the work they were doing or to judge their knowledge and skills. That was really wanted to make that quite clear from the beginning, that we're here to partner with you in the care of these patients. And again, as we establish this program, thinking about how we maintain the relationship once the program is in place, supplementing perhaps with outreach education, offering skills stations. And when there are cases that are complex or outcomes that may be viewed as suboptimal, offering that additional support through case reviews. So we found these strategies are really helpful, both kind of during program initiation as well as program maintenance. All right, next slide. I think with that, I may be passing it off to Ed.
Thank you, Jen. It's interesting. The practice of medicine has always been based on trust, and the key underlying theme here in identifying and engaging those stakeholders is ensuring that face-to-face experience where there's a transfer of trust is exactly replicated in a virtual setting. I would also say that the success of the telemedicine project is directly proportional to the amount of effort that's put into the planning phase, and identification and management of stakeholders is crucial. I'm going to now ask Dr. Weiss of Charité to contribute his thoughts on the approach to identifying key stakeholders within their program at Charité. Björn.
Thank you very much for this introduction, and it was great to hear how actually Jen and the Mayo Clinic with their teleneonatology program made it and have actually been very successful. So in Germany and at Charité, it's very important to get, from a Charité perspective, the approval inside the clinic. And it's pretty much the same that it is at Mayo Clinic, that of course you need support by the management structure, by the clinical committee that is responsible for it, but also, especially if you want to do research, you have to be aware of potential ethical committees. Many programs that start want to combine the start of their telemedical program with a research project, so don't forget, if applicable, apply for your ethics. The second thing is, what you wouldn't need is cooperation contracts. So what you actually want to have is the stakeholder that is actually responsible, the attorneys that are responsible for that. So we really had to get in our legal department at the very beginning to make sure what kind of cooperation this would mean. We, of course, did also involve the IT and developed an IT workflow within our framework, because you have to decide whether you want your program within your core network, or especially if you have, for example, the situation that you have EHR systems or EMR systems outside of your hospital, if you want to access them via VPN, or if you want to access them on a platform outside of your core network. So having this in the concrete case of the ERIC project, this was really important, because what we did was actually we decided to have all of that in a so-called demilitarized zone of Charité. So we do not run our telemedicine program in our core network where our own EHR is running, but we run it outside, which makes it safer from an outside and inside perspective. So then, of course, we have to involve the DPO. The DPO, the Data Protection Officer, is an extremely important stakeholder, especially in the European Union, where EU GDPR is in contract, and you need to prepare a data protection risk assessment of the whole thing you are going to do. And it's very important to do that not only in a timely manner and start with that from the very beginning, but for me, the most important point is actually to also do it in a structured way, in the way your institution wants it to happen. So really try to get involved with these people at the very beginning. What you also need is you need to do an information security assessment, which is mandatory in the European Union, but I really recommend you to have all this data available, because this will actually be easier for you. And in case of Germany, the spoke sites, the remote hospitals, will also require that from you before they will sign any contract. So when we look at the originating remote hospitals, when we set up the workflow and the program, we actually did something like an initial face-to-face meeting where we presented the program. Not only with the department chair in our case, but usually with a whole group of clinicians in the ICU, because often it was a pretty democratic decision of whether or not ERIC and the telemedicine would be implemented. So denial or approval is the next step, and then you again work with the cooperation contract. And from my personal experience, it makes sense to have your legal service involved and have a legal communication, a peer-to-peer communication, which makes it much easier. The contracts are usually then going for GDPR approval in all of the remote spoke sites, and you will also have to contact the local IT contacts. So in summary, for me, it seems paramount that you engage all of these different departments at your department and start with a pilot project, maybe with 1 or 2 hospitals only, and you have all of these things ready in your hub, if you want so, and then reach out to the originating remote hospital where you actually want to engage with people. And it is really, really important then to talk to people personally and to also have matching counterparts on the other side. So for me, this is the most important stakeholders as far as I am experienced with it. And I hope that was helpful.
Yeah, many thanks, Björn. That's really useful. And I completely concur on the significant importance of data sovereignty, data protection, overviews, and security assessments. Fundamentally important in almost all countries. I think I'm going to ask both Jennifer and Beth at the Mayo Clinic to maybe reflect on some of these aspects that they've engaged with across their 19 sites around the United States.
So I'll say a bit, and then I'll invite Beth as our operations expert to weigh in as well. But I really appreciate Bjorn. I was really focused on kind of the clinician stakeholders. But to your point, given what we're trying to do with telemedicine and all of the other infrastructure that's involved, it is so critical to think about, who needs to be involved from your IT IT department as you think about technology selection, installation of technology, recognizing, as Bjorn said, this is often a contracted service. So recognizing that you'll be working with your legal team to make sure a contract is in place between, distant and originating sites that really protects both sites and make sure the desired service is being provided. So I think, recognizing that all of those teams need to be involved early, again, is important for success. And if your organization has any, digital health teams or virtual health teams, again, bringing them in. We have the benefit at Mayo Clinic of having a Center for Digital Health, and we do really rely on their experts again, and legal and compliance, privacy and security, contracting, implementation services to really assist us, particularly when we're bringing a new site up. The one other thing I will just mention is, as Bjorn had mentioned, this idea of when you're a pilot program, one thing we did when we were selecting our pilot site, which you can see was this hospital in Mankato, Minnesota, was it was a site that we had a very strong relationship with, and they were our first site. And so when we met with their team, we were very transparent. We said, hey, we have not done this before. We're quite sure we're not going to do it right the first time. And so we are really going to need your feedback and your perspectives to let us know what's working, what's not working, what we need to change or improve versus what is working really well. And I think when we went in and set those expectations, both of knowing we weren't going to be perfect, that we really needed their engagement and partnership to help get us to a program that met our performance goals, I think really set us up nicely. And then we could take what we learned from, the first implementation and apply it as we scaled up. Beth, you probably have a lot more and refined information to add.
Yes, and thank you for having us today. I think the meetings with IT, the compliance teams, they're vital. They're very important to bring those stakeholders in at the very beginning. And while we can talk at length with that here, I do reference how you can do that when we get into the workflow design and telemedicine products section. But I think one of the main things that we learned and we did here at Mayo with the teleneonatology program is we brought a few key members of our IT and data and privacy teams into a meeting, and we actually had them listen to a call that we had where there were technical failures occurring during a phone call activation for teleneonatology, and it immediately got that team thinking differently about the fact that telemedicine products are not the same. They're not equivalent to your electronic health record. They're different. They need to be supported differently. And that initial engagement changed the conversation that we were able to have with our IT colleagues. And it sounds like Charité had a similar experience with bringing in a product and telemedicine that's on a separate network than their EHR. And that's necessary in certain use cases, especially when we're talking about emergency care. So thank you. And Ed, I'll hand it back to you.
Thank you, Beth, and Jen and Bjorn for those observations. And Beth, don't go anywhere because you're coming up shortly. So this is time for some homework for you, our audience. Reflecting on the presentations from the panel members thus far and the situations within your own health systems, we invite you to think about and document the key stakeholders and contributors to your program. Some categories to consider. It's not an exhaustive list, but thinking about the distant hub site, the departmental chairs, the division chairs, the managerial executive team, the IT leadership and the specialists therein, the remote clinical community, and at the spoke sites, similarly, group of similar people, also including the nurses who are fundamental to the process of delivering care at those originating sites, but also include corporate communications, because this can be a complex organizational change management process, internal and external marketing to communicate the value internally and to your identified patient community, and also the patient representatives. We're doing this to improve the care that we deliver to patients, and their input is fundamental to this process. Now, these workshops or these little worksheets are available as part of the IHF package for you to download. So we're not going to be asking you to fill these out right now. This is a very content-rich webinar, but we would strongly suggest that you take time to consider who your key stakeholders are and to document them out in preparation. So Beth Kriofsky is an assistant professor in healthcare administration and an operations manager supporting the teleneonatology program at the Mayo Clinic in Rochester. Ms. Kriofsky has over 20 years of experience in healthcare, which includes clinical process experimentation, project management, product management, and systems innovation. And there's really no one better to learn about operationalizing a telemedicine program. And in this part of the program today, we're going to be looking at the issues that are fundamental to workflow design and program implementation. Beth, if you would be so kind as to walk us through some of the aspects of workflow design that you undertake at the Mayo Clinic. Thank you.
Thank you, Ed, and greetings, everyone. I would like to talk to you today about the workflow design and why it's so important. When we understand the issues that are fundamental to building a program, we can better implement and we can be more successful in sustaining that implementation and building a program that is usable by our remote clinicians as well as our distant site or our originating site care teams. So the main elements that we consider with every implementation that we have is service activation, telemedicine product selection or technology performance and platform selection, and then the documentation requirements at both the originating sites and the distant sites. So I'm going to walk through why these elements are important to consider. With a telemedicine consultation and just telemedicine in general, there's this tendency to identify the products first and then want to immediately put them into place and start using them. But something that has to be considered is how are we going to use the products? How are we going to meet the needs of the care teams and the patients? So we need to define a process in which every person that's going to be working within a telemedicine program or within a hospital that receives telemedicine knows what to do and when. So defining each step in the process is very important to making sure that everyone knows what to do on the day that you implement. When it's clearly defined and we have an efficient workflow and it's compliant, we know that it will be able to be integrated seamlessly into the practices that we're implementing too. We also at Mayo Clinic provide provider resources, both for our clinicians at our distant sites and our care teams at the originating sites. Our teleneonatology quick reference guides highlight the steps in which each of those roles participates within the workflow. And what is useful about these is it takes some of the guesswork out of how to activate the service, where to position the device within the room with the patient, and how to answer the call that's coming in on the clinician's side. So we provide these to alleviate some of the guessing that can happen in a very high stress, high anxiety situation that the care teams might be going through. Our median response time at Mayo Clinic is under 5 minutes to have someone on video. We want to make sure that we have performance goals that we're trying to maintain and achieve, because we know if it is a full resuscitation of an infant, the care teams at the local sites feel like 30 seconds to a minute is, it seems like a millennial to them, and we want to make sure that we can get them the support that they need as quickly as possible. We also measure satisfaction of our care teams that have performed teleneonatology consults with us. The likelihood of them to recommend the use of teleneonatology is over 95%. And that's measures that we track along every consult that we do. We send surveys, and we make sure that we're meeting those needs, and we're meeting the needs of the care teams that we're supporting. Next slide. So for workflow design, a part of this is selecting the telemedicine product. We've talked a little bit about the telemedicine products. These are usually the tangible things that people get excited about using. You can see it, you can see how they function, but it also comes with some work that has to be done both on the IT side as well as on our clinical side. So we have these three fundamental features that are required when selecting a telemedicine product. So performance requirements depend on the use case. So when we're looking at selecting technology, we have to determine what does the clinician at the remote site need to see and hear, and what do the care team members need within the space that they're functioning in. If they have a limited space within, for example, a resuscitation room, we have to make sure that the products, the technology that we're selecting isn't going to replace a human at the bedside. It needs to be available and always on, and our clinicians need to be able to function within that setting. So the performance requirements depend on the acuity of the patients and what the needs of the care teams are. Privacy and security are fundamental. When you're looking at the types of emergencies that our clinicians are assisting with, there are things that we want to make sure are not recorded. There are things that we want to make sure that the data is not being stored anywhere, but we want to make sure that it's a program that is meeting all of the compliance rules and regulations within the United States or within whatever region or country that you're located in. And pulling in those IT colleagues in your telemedicine teams can really help with selecting the telemedicine product and making sure that it's meeting the needs of GDPR or any other rules and regulations within your region. We do know from experience that poor system performance can lead to a reduction in program use. If the technology is not going to work the first time they attempt it, people are going to revert back to using phone calls or requesting transport for patients that maybe don't necessarily need to transfer because of the medical stability of the patient. So if we have systems that are not performing at their highest performance levels, we're at risk of the volumes of our service going lower, and also not not being used by our care teams in the remote sites. So next slide. Okay, so these are really the four main features: the reliability, the functionality, the usability, and the interoperability. It needs to be reliable. It has to work 100% of the time. We know that 100% in an IT world is not something that they'll agree to, but we can get them to agree to 99.9%. And so those are the things that we want to try to get to. Functionality, we need the remote physicians to have camera controls, and audio quality needs to be very high. If they need to be able to use a portable ultrasound machine, we need those systems to be able to be accessed easily by the care teams. And we need them to be non-invasive into the care environment. So by allowing the remote consultants the ability to control the cameras and control the audio settings, we take some of the tasks that would have originally fallen on the care team at the bedside off of them so that they can perform patient care and tend to the patients. The usability, again, both hardware and software has to be super easy to use for both the care team and the clinician that is performing teleneonatology consults. And interoperability, there are some use cases that require the ability to view images or to access your EHR data in order for teams to make decisions on how to help advance the patient's treatment plan. So when that occurs, having your IT teams evaluate how you perform telemedicine and link that back to your EHR when it's necessary are fundamental in making sure that you're designing for the patient need and the needs of the care team. So this staffing model, there are things within a staffing model that need to be evaluated. With teleneonatology, we know that emergencies can happen any time of the day or night. 27% of our teleneonatology activations occur on the weekend, and 40% of our activations occur between the hours of 7 p.m. and 7 a.m., with a majority of those happening after midnight. So we need to be able to staff to when those emergencies could potentially happen, and we need to be available. We also have taken the stance at Mayo Clinic that we will have board certified neonatologists perform the telemedicine consults. We do have programs where advanced nurse practitioners and others participate in the telemedicine consults. But according to in 2020, the American College of Emergency Medicine did provide guidance on emergency telehealth and acute care unscheduled telehealth, stating that emergency telehealth may be utilized by or in consultation with a board certified physician. So having that board certified expert, having someone who may be being called on by another board certified physician, we want to make sure that whomever is activating our service is getting the highest level of support for the use case at hand. So with neonatal medicine, premature patient care and premature baby patient care is in our mind best suited to be served by our board certified neonatologists when our pediatricians activate our service. For facility to facility care, when we're performing consults, the primary responsibility does remain with the local care team for that patient. So in the event that we're consulting with that team, we want to make sure that the site, the local care team, has the resources and the staff available to be able to care for the patients in a safe manner. Our team enhances that, and we can add to and help the pediatricians and the care teams at the local site, but that primary responsibility for the patient remains with the local care teams here in the United States.
Yeah, thank you for that, Beth. Dr. Weiss, you talked earlier about the staffing model at Charité, and I think it'd be really useful for our audience to understand how you deliver that staffing model across multiple different country geographies. Would you be able to share some thoughts with us on that challenge, please, Björn?
Sure. I focused on the national telemedicine program, and obviously in Germany we speak German in all the hospitals. However, if you plan to do an international program, you have to be aware of determinants that do not account in a national or local context. The workflow should, of course, involve the time zone, the language, but also other things like cultural aspects of care and the infrastructure you're working in. So, for example, recommending a medical measure in your workflow or recommending a referral in a situation where you don't have a referral hospital doesn't make sense at all. So these are things you really need to explore. And the question is also, what kind of coverage model do you really need? Do you really need the 24/7, 365 model, or especially in international programs, would you rather go for a round model without the response opportunity within like 30 minutes? So the way we do it is we are available for acute questions, but we do not deliver the same 24/7, 365 referral service we actually have for the hospitals that are in our region here. So this is definitely something. The next question I think is really important, and I can only echo what Beth said. The question is, who provides the telemedicine service? And it needs to be very clear that you need an expert there. It is not even sufficient in our case to just have a board certified intensivist, but you need an expert intensivist who is actually giving meaningful, advices to the person at the other end of the line. And you also need advanced practice nurses, etc., that actually give good recommendations. And what is really important is also clarifying what kinds of responsibility and decision-making authority lies within the telemedical team. In our case, it's a consultancy, so the ultimate treatment responsibility, as for example also at the Mayo clinic, remains within the local care team. So if they disagree with a recommendation made, they can go their own way, because sometimes, and this happens now and then, the recommendation you make has not taken into consideration all aspects that the others have, for example also local resources, etc. So this is a really interesting question. I would say if you do a program in a region, in a local region, and if you staff a program which has the purpose to also serve a community and potentially organize referrals, it definitely makes sense to have 24/7 coverage. If you do international programs over different time zones, make sure that you have the rounds implemented and to make the rounds to a good time. And I mean, the maximum time difference is 12 hours. So that means you would have to do the round in the very early morning, and it would be early evening in the other centers. So I think it's possible worldwide. The response thing is a little bit more difficult, of course. I hope that answered part of the question.
Yeah, it's great experience, Björn. Charité and the work that you're doing across sub-Saharan Africa and Uzbekistan, so valuable.
Absolutely, Ed. And the staffing model, I can tell you, and I think this is also probably interesting for the audience. I think if you want to do the investment and invest into a telemedical program and take this into consideration, the staffing will be what is really the major investment into that. It's not so much about the technology and about all these things. What you think about, you probably think, okay, the technology is of that and that value, but be aware that for a good telemedicine program, you need dedicated staff and you need well-trained staff. And this is really paramount for the success of any program.
Absolutely, Björn. Thank you for that. And again, thanks, Beth, for your observations. So once again, we turn to some homework for you, the audience, and reflecting on the presentations that you've heard from our panel today and the situations within your own health systems. I invite you to think about and document, not now, we're going to move on very quickly, but think about that workflow design and how you can meet those performance goals informed by the use case. And so again, these are worksheets that are available on the IHF website and available for download. But we have 9 minutes left, and I'm going to invite Dr. Weiss, again from Charité, to talk a little bit about implementation timeframe. Björn, over to you.
So I think the most important point when you talk about program implementation is that you really are aware of everything you want to do, and you have this target date for a telehealth program to go live. You have to schedule the relevant staff training, and you should do that well in advance. I would say a realistic time frame for the implementation of a program is probably about a year. having goals and also having communicated goals, of course, keeps you and the team accountable for moving the project forward. That's very clear. And I think it's really important that you have these kind of checks in between where you can also look how far advanced is the program, right? I would recommend always starting with a small, I already said that, with 1 to 3 pilot size, because it simplifies the design, it requires fewer resources, and it allows for rapid learning and improvement, of course. But maybe next, if you go to the next slide. So what we did is actually, we did a pretty intense implementation strategy because you really have to know that virtual care is not the kind of face-to-face care. It can be of the same value and you can achieve a lot with that, but you're not working in your own team, you're not working in your own environment, but in contrast, you're working in a completely different kind of situation. So simulation sessions are, for me, very important. And it's not about simulating the telemedicine, because that's working pretty fine. It's also especially simulation sessions on the entire workflow prior to go live, and especially for low volume sites. I think this is especially something Jen can elaborate on, Dr. Fang, because low volume site, that means sites that are not, not having the same volume as you in cases, so they need to learn it and they need simulations. You need to monitor program performance, of course, so you need something like a quality insurance. You can do that as a research project, or you can use a normal thing like a quality management, but you should seek for user feedback and, of course, continuously improve like the program by also doing so. We do PDCR checks, and we have a quality management implemented on all of our clinical programs, including telemedicine. In the case of Eric, and I want to elaborate on that a little bit, I think we framed all of this, and I want to show you that because I think it's interesting. We framed all of that into a research program, and it is a cluster randomized controlled trial where we started with a control condition period where all hospitals were actually trained 4 weeks before going to a crossover point, which you see where the gray goes to the I think it's like lilac or something like that thing, where they actually developed into an intervention condition where they got telemedicine, and that was called the rollout period. So we actually really measured the quality before the implementation of telemedicine in our network. We had the crossover point, we went into the intervention condition, and then we continued monitoring. This trial design did not only help us to evaluate the meaning of telemedicine and the efficiency of telemedicine, but it also helped us to have exactly what we've shown you before, the different kinds of landmarks and milestones you need to implement a telemedicine program into daily routine. So in each of the clusters, or in each of the sequence groups, we had 4 clusters. 4 clusters means 4 different hospital companies that were attached to the system. And then we went into a post-rollout period and a sustainment. And just to your information and the to give this kind of a measurable timeline, we started in September 2018, and after a 1-year period of preparing the program. And then 3 months later, we attached the first 4 hospitals to our network. And then every 3 months, another 4 hospitals was added until the complete cluster of 11 hospitals in the, because one actually dropped out, and the total of 11 clusters being attached to the program, and then having this post-rollout period. And I highly recommend, whether or not you do research, I highly recommend you to have such a plan and to have such a very clear imagination of what you're doing and when you're actually doing it.
Okay, Björn, thank you very much for that comprehensive overview. Karen, if you could advance to slide 26, please, as we are running close to time. So this session has really been focused on the stakeholders and the workflow and the implementation timeframes to deliver a telemedicine program. Identification and early engagement of stakeholders is fundamental to this. The workflow should be designed to meet performance goals with special attention to things like service activation, technology selection, staffing model, even in an international delivery framework, and supporting documentation. Work with the team to select your pilot sites and set a go live date and a timeline with gateway checks to ensure you can maintain the momentum that you've worked so hard to build. And consider using implementation strategies that address feedback, training, and refinement. Then, first of all, I'd like to thank Dr. Fang, Dr. Weiss, and Ms. Kriofsky for sharing their extensive experiences with us today. We've learned a lot today. Every day is a school day in telemedicine. Most importantly of all, I'd like to thank you, the audience, for spending time from your busy lives and your evenings and maybe even your nights with us today. And I hope that we've been able to help you in your journey to transforming your healthcare systems with virtual care. And finally, I'd like to thank the IHF and their team for supporting your community in this way. Before we close, I'd like to remind you of the next meeting. We'll be continuing this conversation at our next workshop on December the 7th at 16:30 CET. And we'll be looking at defining and measuring program success. As for the first session, a recording of this second workshop will be made available, and all those who attended will receive a notification once the video is live. We will also be taking your questions that you've been so kind to post to the forum, and we'll be responding to those offline, as I'm afraid we ran out of time today to address them live in the session. And it just remains for me to thank you all and wish you all a great day, a great evening, a great night, or a great sleep, wherever you are in the IHF universe. Thank you very much, everybody.